Thank you so much, everybody, for attending today's webinar. This is the Ask the Expert questions submitted by the Collagen VI and Collagen 12 community. The format for today's webinar will include answers to questions that have previously been submitted from the community. If at the end of this presentation you have additional questions, we will share an email address where you can submit those questions. CMD is also planning the 2017 CMD Scientific and Family Conference, July 7th through 9th in Arlington, Virginia. This is another really great opportunity for you to ask questions and learn from the experts in our disorder, as well as families and affected individuals with Collagen VI. So we really hope to see you there. I'd now like to introduce our host for today's webinar. Dr. Carsten Bonnemann is the senior investigator and a neurologist at the National Institutes of Health. Dr. Reghan Foley, also a neurologist and investigator at the National Institutes of Health. Dr. Hank Meyer, a pulmonologist, director of the Pulmonary Function Laboratory at Children's Hospital, Philadelphia. Dr. Gustavo Diaz-Chapolsky, and myself, both from CMD. Okay. Dr. Foley, let's have you take over.
Sure. And Dr. Bonnemann, you could always chime in any point in time, of course. Rachel had put together slides to kind of summarize the questions which had been submitted. And the first slide of questions is what is Collagen VI and why does it matter? And there's a question that was submitted, what is Collagen 12? And it's similar or related to Collagen VI. So Collagen VI is an extracellular matrix protein. You can see in the diagram, and it provides support to the extracellular matrix. That support is essential in its relationship to the sarcolemma and its contractions. And when collagen VI is either aberrantly formed or absent, it will really result in a muscle breakdown over time because of that lack of structural support for the sarcolemma. And what is Collagen 12? So Collagen 12 discovery came from Dr. Bonnemann's laboratory, and Collagen 12 presents and manifests in similar ways to the phenotype or clinical presentation of Collagen 6-related muscular dystrophy. So similar manifestation. Another form of collagen. Next question being, does Collagen 6 and 12 affect the mitochondria, and how is it related to ATP production? So there is a research group in Italy who has studied the relationship between Collagen 6 and functioning of the permeability transition pore of the mitochondria. And so their data has shown that in the condition of deficiency in Collagen 6 that the mitochondrial permeability transition pore functions abnormally. And so they have evidence in the Collagen 6 mouse model that mitochondrial function is affected, and there's a tendency towards increased apoptosis or cell death secondary to this abnormal mitochondrial functioning. Again, felt to be a secondary effect from the Collagen 6 deficiency. So, and slide number 4, the signs and symptoms. And so basically important to kind of lay out that the Collagen 6-related congenital muscular dystrophies have a spectrum of clinical presentations. So the subtype known as the Ulrich congenital muscular dystrophy presents at birth and also has typically a history of decreased fetal movements during the pregnancy. And at birth it's common to see kyphoscoliosis, hyperlaxity of the distal joints, hip contractures and contractures of proximal joints, as well as abnormal positioning of the hands and feet. And so in the pictures that Rachel has provided, you know, the hyperlaxity of the distal joints mean the furthest from the center of the body, the fingers is very common, as well as joint contractions of proximal joints. Over time, atrophy of muscles and skin manifestations, including hyperkeratosis pilaris on the extensor surfaces of the arms and legs, respiratory involvement over time, and a rigid spine or a development of scoliosis over time. So there's a question submitted, will I develop all of these symptoms? Typically, patients with Ulrich congenital muscular dystrophy will have the manifestation of symptoms at birth and over time would develop all the symptoms listed on the slide. Those patients which fall in the clinical category of what we term intermediate-related collagen VI muscular dystrophy typically do not have as many symptoms early on, but do progress to a clinical picture similar to Ulrich congenital muscular dystrophy over time. And so most of the manifestations in this slide would be seen in the intermediate patients. Most importantly to note is that there is respiratory involvement in intermediate patients later than we see in the Ulrich congenital muscular dystrophy patients, but still a need for the initiation of nocturnal non-invasive ventilation or BiPAP, bi-level positive airway pressure. In intermediate patients, on average, nocturnal BiPAP is needed on average by around 21 years of age, plus or minus 4 years. And for the Ulrich congenital muscular dystrophy patients, the onset of nocturnal BiPAP by around 11 years of age, again, plus or minus a few years. That's the data we have from our international series. For Bethlehem myopathy patients, the manifestations in childhood are less prominent. There can be hypotonia, decreased tone. There can be still some evidence of tightness of the long finger flexors. You can see in this picture in the bottom of the slide. It's kind of a classic Bethlehem myopathy sign when you try to put your hands together in the position of a prayer position, that the fingers cannot fully extend. That can be seen in childhood during childhood patients with Bethlehem myopathy. Over time, Bethlehem patients develop a progression of joint contractures, and patients may need the use of nocturnal BiPAP beginning in adulthood. The data we have for Bethlehem myopathy is it's not a very statistically significant trend that all patients will need nocturnal BiPAP, but most patients may manifest that need over time and should be clearly monitored. So the last question being, how do I know if I'm Ulrich, intermediate, or Bethlehem? So kind of just to recap, patients that either never achieve the ability to walk or lose ambulation by approximately 10 years of age would be considered Ulrich congenital muscular dystrophy patients. And pulmonary manifestations for those patients include a decline in pulmonary function early, and it's invariable, with a need for the onset of non-invasive ventilation by approximately 11 years of age. Intermediate patients lose ambulation by approximately 19 years of age, give or take a few years. And there's a decline in pulmonary function, which starts slightly later than we see in Ulrich congenital muscular dystrophy patients, with a need for non-invasive ventilation around approximately 21 years of age. Bethlehem myopathy patients typically walk until adulthood, but may need walking aids by around the ages of 40s or 50s. And decline in pulmonary function is more variable, not a consistent trend per se, but typically after the age of 40, many Bethlehem patients do need nocturnal non-invasive ventilation. It's important to highlight, too, that the knowledge we've gained from studying the international cohort about the need for nocturnal non-invasive ventilation has been absolutely pivotal knowledge in terms of providing our collagen VI patients with information that helps them to anticipate any future pulmonary needs, and the timely initiation of nocturnal BiPAP has enabled many of our patients to stay very stable from a respiratory perspective and avoid significant chest infections or hospitalizations. Diagnosis.
So genetic testing can tell to a certain degree whether what type you have, but it's not a perfect correlation. So we know that if you have mutations in the collagen VI genes that are causing collagen VI to not be there at all, so we call those recessive null mutations, so mutations on both copies of collagen VI that do not allow collagen VI to form at all, and that is invariably an Ulrich phenotype, a severe phenotype. But more commonly, and that's where it gets complicated, mutations in the collagen VI genes are actually dominantly acting mutations. So the mutations where there's a mutation only on one of the two copies, And that may be inherited if the parent is also affected, or maybe de novo, so it's new in just the child or the offspring. And those act by a dominant negative, or if you will, toxic mechanism. And some are more severe and some are milder, and they really span the entire spectrum from Ulrich via intermediate to Bethlehem. So for typical Ulrich mutations that are commonly occurring in Ulrich patients, we know there's almost for all of them there's a spectrum that ranges to also intermediate. And then for milder mutation, there's a spectrum that ranges from intermediate to Bethlehem. So what I'm trying to say is for a dominant mutation, you can often say, well, this is more common in Ulrich and intermediate, and this one is more common in intermediate or Bethlehem. But it's rare to be able to say this is a mutation that invariably causes a particular phenotype amongst the three. So there's variability, in other words, and the mutation can tell you somewhat where you're going to fall in the spectrum, but it's not an absolute correlation. So if I have a mutation that's not been previously reported, does it mean I have a collagen VI disorder? So that's where it gets very difficult, because the collagen VI genes are full of variants that are variations of normal and that are not causing disease, but that have also not been previously reported or recorded in databases. And so genetic testing lab will then say, well, this is a mutation that changes the amino acid sequence of the protein and has not been previously reported. It could be associated with a collagen VI disorder, but we don't know, and they call it a variant of uncertain significance, or VUS. And then it gets very difficult, because then it depends on whether this is really causing the disease or not. And many variants that we have seen and reported to us as questionable collagen VI disorders ended up being not disease-causing. In other words, if you get a genetic report with a previously unreported mutation that is a variant of uncertain significance, then it becomes very important for the care provider and the specialist to see, does it really make sense for collagen VI disorder? Do you really have the phenotype of a collagen VI disorder? Is this a mutation, the type of which we would predict to cause disease or not? And that's when sometimes things have to be quote-unquote escalated to talk to specialists or people who've seen a lot of mutations and patients like our group has to see, can you help us? Do you think this is actually related or not? And sometimes additional testing is necessary on fibroblasts to look at collagen VI production, or even the muscle biopsy to look at collagen VI localization. But often the clinical phenotype and the muscle imaging will be very helpful in trying to figure this out. So it's a difficult question. There's not a one-to-one answer to it. And sometimes it's a clear mutation that we think is really pathogenic just by the look at it. More often it's a variant that has not been seen in collagen VI or in the normal populations, and then one has to really dig deeper and do due diligence to really sort out whether it is collagen VI disorder related or not. And sometimes it's really difficult, and before someone gets quote-unquote stuck with the wrong diagnosis, it's worthwhile to really go all the way to try to prove or disprove that. So that also, I think, answers question 3. So if a mutation has not been previously reported and the genetic report is lukewarm, meaning they don't commit to say, well, this is really disease-related or not really disease-related, then you should tell someone, and someone should work with you and try to find out, does it mean anything for me? Do I really have a collagen VI disease or not? And really, that's where one has to pull people in who have seen a lot of this, and we are always happy to provide advice if this remains unclear. So the fourth point is an interesting one. I've been told I probably have collagen VI, but I can't find a mutation. That's a very true scenario, and then it becomes really a specialist testing requirement here, because if you really have a collagen VI disorder by all criteria that Dr. Foley outlined in the previous slides on the clinical slides, and really a specialist would say, well, this is collagen VI until proven otherwise, but there's no genetic mutation, then one has to insist that there still could be one, and one has to dig deeper to find it. And so in our group, as part of an international effort, we've just solved one of those where the mutation was so deeply hidden in the collagen VI gene that it could not be discovered with conventional genetic testing methods. And it really was using special methodology we call RNA-seq and whole genome sequencing that we were able, together with the Broad Institute, to find a mutation that was really deeply hidden in the uncoding parts of the gene, but that caused classic collagen VI disease. And that explained a lot of patients who were told to have a collagen VI disorder, but where the mutation couldn't be found, that are now explained. But there's still unexplained patients like that out there, and it's an ongoing project for us to try to identify additional mutations that could do this. But sometimes the answer is really even more simple, because the genetic testing hasn't been exhausted all the way. So the regular genetic testing is direct sequencing, but sometimes there is a deletion, so loss of bigger pieces of genetic material in the collagen VI genes that hadn't been looked at. And so it really then requires just an additional round of testing from the genetic laboratory to do this. It is all really dependent on how convincing the collagen VI clinical phenotype is, because sometimes you're told you have a collagen VI disorder, but it looks clinically very different. And then, of course, you can dig as deep as you want in the collagen VI genes. Nothing will be found because you have a different disorder. Again, that requires a specialist look to really say, and sometimes additional testing on muscle and skin to really say, well, this is a collagen VI mutation, and then we have to find the mutation, has to be there, as opposed this is really not a collagen VI disease, and that's why we have to look for different genetic mutations in other genes. How often should I see a neurologist once diagnosed? And maybe Dr. Foley, while I mute myself to do some coughing, maybe Dr. Foley can comment on that.
Of course. So once you're diagnosed with collagen VI-related congenital muscular dystrophy, we recommend pretty close follow-up with a multidisciplinary neuromuscular team. And so that would be a neurologist, ideally with some experience in caring for patients with neuromuscular conditions, pulmonologist, cardiologist, orthopedic surgeon, physiotherapist or physical therapist, an occupational therapist. Ideally every 6 months, particularly during the early childhood years, and most importantly, I would say, to keep very good close eye on pulmonary function and to anticipate pulmonary needs. And if there is the availability of a subspecialty or a multidisciplinary neuromuscular clinic, that would be ideal. I'm aware that many centers don't have that, and so I would say seeing a neurologist should occur ideally every 6 to 12 months, and seeing a pulmonologist every 6 months without fail, and then making sure you try to pursue also the input of an orthopedic surgeon, physical therapist or physiotherapist, and occupational therapist, and also ideally input from a nutritionist as needed. For the question, if we are followed by the Bonnemann team at the NIH, how often should we return? We have a natural history protocol for studying rare neuromuscular conditions, including collagen VI-related CMD, and have been focusing on studying very carefully the early manifestations in collagen VI patients, because some of that data is less prevalent as the manifestations over time. And so we typically are encouraging for our young patients, that is, from birth until age 5 or so, that they come back, if possible, annually to gather that history very carefully for the early manifestations. And for other patients that we have seen here, it's a more depends on the particular situation of the patient, but Once every 2 years usually is what we would recommend, more or less. And then those patients who are older and stable, we certainly serve as a point of reference for your local team, but wouldn't be seeing you frequently here so much. One thing to note is we are trying to do also some surveillance in the older patients of looking at using cardiac MRI to look at vessel size, particularly the aorta, in patients with vessel myopathy. It remains unclear, and I know this is a question in a subsequent slide, but it remains unclear to us if there's an association between collagen VI deficiency and widening or dilatation of the aorta. If this is related to collagen VI or just an inherited condition unrelated to collagen VI. And so for our adult vessel myopathy patients, we are providing surveillance of aorta in those patients approximately every 2 years.
Yes, and sometimes new studies will emerge, so there is a new technology that we have to investigate, or even a clinical trial, and then of course we will reach out through CMD-IR and Cure CMD to the community to see that we can get information out and perhaps get volunteers to come to the NIH if there's new things that we need to investigate or new trials.
So the next slide, questions about cardiac involvement. Is the heart involved? So in collagen VI-related congenital muscular dystrophies, there is not primary cardiac involvement. I say primary meaning related to the collagen VI deficiency. However, we have seen in some patients that if the pulmonary requirements, basically if the BiPAP pressures are not sufficient to maintain good ventilation at nighttime, there can be secondary cardiac manifestations, namely in the form of right-sided heart strain. And these findings do resolve once BiPAP pressures are improved to the adequate pressures needed for good nocturnal ventilation. So we do recommend that cardiac function be monitored by echocardiogram. Typically, also EKG is performed the same exact time as the echocardiogram by most cardiologists. We have not seen any cardiac rhythm abnormalities in any of our collagen VI patients that we've studied, but echocardiogram is the best for monitoring function. And how often, it's a great question. Most patients are very stable from the cardiac perspective, but again, those patients on non-invasive ventilation in the form of BiPAP probably should have echocardiogram approximately every 2 to 3 years just to make sure there's not any sign of heart strain. But again, if your BiPAP pressures are adequate, there should not be heart strain. Pulmonary, I'm well aware that we have Dr. Hank Meyer on the line, and he's our go-to neuromuscular pulmonologist, who's been exceedingly helpful for all of our questions. So Hank, please jump in.
Okay, happy to participate here. And the first question is, what are the signs and symptoms of breathing function, that the breathing function is declining? And I'll answer this in the realm of sort of clinical function as opposed to pulmonary function testing that one gets in a PFT lab. And the two general categories that we get concerned about, one is airway clearance, clearing mucus, expectorating secretions during an illness. And the second is ventilation. Dr. Foley mentioned BiPAP multiple times, and the first thing that we get concerned about is the ability of a patient to be able to clear secretions during a respiratory illness. And if you think of what a normal cold duration would be, for most people it would be peak symptoms occurring between 3 and 5 days, and then the symptoms generally going away completely by about 7 days. And so if you're having, or your child is having cold symptoms that are lasting, upwards of a week towards 10 to 14 days, that would make me concerned about their ability to be able to expectorate mucus. And if that were the case, then we would certainly want to refer a patient to have assisted airway clearance with a device like the COPAssist. There's not a very good link between needing airway clearance support and pulmonary function testing, though there is a a somewhat, well, it's not really new, but it's a not widely done measurement called peak cough flow, which measures the peak flow that you can generate during a cough maneuver. And there's some data in the adult world that correlate peak cough flow with a inability to clear secretions, or suspected inability to clear secretions during a respiratory illness. And so that's about the only functional measure that we have that indicates difficulties with airway clearance. And then the other functional issue is related to needing assisted ventilation at night. And the first signs of that are really related to things that are nonspecific and related to poor sleep, such as fatigue during the day. For younger children, it might present as behavioral problems during the day, especially in the morning, until they sort of wake up and sort of kick into gear. For patients that are retaining carbon dioxide at night, which is what leads to the sleep problems, you can wake up in the morning with a headache that usually takes about an hour or so for someone to get through. And so the other thing that I always try and pay attention to is whether the progression of loss of muscle function and weakness changes trajectory. In other words, if the fatigue starts to increase at a rate much more significant than the previous trajectory, then that would also make me worry about whether there's a potentially treatable cause, such as chronic respiratory failure at night. The best way to be able to identify that with precision is to do a sleep study in a pediatric sleep lab. So doing a pulse ox study to measure oxygen level at night is a loose surrogate. It's not really a good. It's not really a good substitute. But that also means that to be able to do a good sleep study, you need access to a tertiary care pediatric center, which becomes a bit of a challenge. And second question is, how and when should I start surveillance and preventative care for breathing function? Over the last 5 or 6 years, my feelings have changed, and I feel that that really should be started from the time of diagnosis, at least, and maintaining a rapport with a respiratory doctor and a respiratory therapist. And there's some suggestion and some increasing evidence that starting respiratory range of motion exercises with deep breathing maneuvers called hyperinsufflation may be helpful in attenuating or altering the rate of loss of respiratory function. There are data that my colleagues from Cincinnati and I have collected that should bring some clarity to that, but there have also been a number of smaller reports in the literature over the last 20 years or so that have hinted at that as being something that could be helpful in preventing or altering respiratory rate of decline of respiratory function. And then the question of does loss of ambulation affect breathing function? I think that's a difficult question. And initially, I think that looking at least the Duchenne data, where there's quite a bit of data, one would say that you lose ambulation and then you lose respiratory function. But I would argue that it's probably a coincident loss of muscle function affecting ambulation and then respiration. So in other words, loss at about the same time. So I think it's really two processes that are going along in parallel, as opposed to ambulation causing a substantial rate of decline. And then for surgical situations with anesthesia, outside of the potential risk for malignant hyperthermia and some forms of congenital muscular dystrophy, as a pulmonologist, I get very concerned about the postoperative management. And for patients that have normal respiratory muscle function, the typical approach after surgery is to use an incentive spirometer and have the patient do deep breathing exercises, which for somebody who has respiratory muscle weakness can be exceptionally difficult, if not impossible. And so what we often will do with our patients is start lung volume recruitment maneuvers, either with the cough assist or using a breath stacking maneuver with a manual resuscitation bag and mask. And that can be helpful to open up underutilized portions of the lungs that may have become collapsed or atelectatic. Not doing that can cause a prolonged recovery time and perhaps require the use of supplemental oxygen, which for a short term is not really a problem, but that need will delay the postoperative recovery time. And then related to that, should oxygen be administered, if ever, or when should oxygen be administered, if ever? And if you're in a situation where there's low oxygen, the first concern will always be whether that's because of respiratory failure and high carbon dioxide. And so if you're in a situation where you are adequately supporting ventilation with BiPAP or an invasive ventilator, then certainly any level of supplemental oxygen is perfectly safe. But again, the most important thing to emphasize is that has to be done only in the face of supporting ventilation adequately. Without that, there's a potential risk of causing worsened respiratory outcomes by suppressing the low oxygen drive to breathe instead of treating the respiratory muscle failure or respiratory failure.
Hank, I think there is one question that came in the chat box. Does swimming exercise help with pulmonary issues?
Well, I would say any type of physical exercise that gets a patient to breathe more deeply can be helpful. There's no data that I'm aware of in neuromuscular disease about specific exercise training, though there are some data on doing resistance breathing maneuvers, using something called inspiratory muscle training. There's probably most data in Duchenne muscular dystrophy, and the conclusions are somewhat variable. Some studies suggesting improvement, some showing no improvement. I have in a small number of my Collagen VI patients, I have started inspiratory muscle training. So I don't know that I have enough experience or the time to see the patients back to be able to say whether it's had a significant improvement.
And then maybe,
still certainly something that would be useful to look at further.
Yeah. And then maybe one more question that should probably also be asked in the pulmonary section is, what is the influence of scoliosis, progressive scoliosis on pulmonary function, and should that go into the decision-making process for scoliosis surgery?
Sure. Well, I think without question, scoliosis, whether it's in a patient with a progressive neuromuscular condition or somebody without, can have a dramatic negative impact on respiratory function. And so I think it's even more important in neuromuscular disease to aggressively manage scoliosis before it gets too severe. The problem, however, is that it's not, when scoliosis is repaired, it's not as simple as, it's not a simple expectation that the lung function that has been lost would be improved simply because the underlying respiratory condition, whether it's congenital muscular dystrophy, SMA, or Duchenne, is still present. But I think it can certainly have a large impact on altering rate of loss of function. And I certainly advocate aggressive scoliosis management.
Reghan Foley here. Just going to comment on one more thing about the ambulation and breathing function. It's important that local neurologists caring for Collagen VI patients are acutely aware that there can be a need for nocturnal BiPAP even while an individual with Collagen VI remains ambulatory. So you don't have to be off your feet to be using nocturnal BiPAP. Sometimes that need is very much apparent before loss of ambulation. And the second thing, just to kind of follow up on Dr. Meyer's comments, is patients that are going to undergo scoliosis surgery, it's important that the intensive care unit caring for Collagen VI patients post-operatively do not rush to extubate. And when they do extubate, that they have a plan in place to extubate to BiPAP, just because, for multiple reasons actually, but post-operatively, there's not going to be a tendency for taking deep breaths due to discomfort, and so the BiPAP is very important. And in the setting of any repeat intubation, typically reattempts to BiPAP a few days later are highly successful. So just kind of keeping the ICU aware to go to BiPAP after extubation, not rush.
Related to that, I will often have my patients with any neuromuscular condition or undergoing surgery and aren't on non-invasive ventilation, at least get introduced to it beforehand and have a plan in place to shift to that, as Dr. Foley recommended after surgery and right from invasive ventilation.
And Dr. Meyer, also, I guess you mentioned too that cough assist should be used prior to scoliosis surgery as well, I guess, right, to kind of help prepare for it? Absolutely.
Yeah, it should. I think having a setting that works well for the patient is very important to have in place before sending a patient to the OR.
I think you can tell we really can't emphasize enough the importance of anticipatory care of the lungs and keeping our Collagen VI patients stable.
And can you address the need for daytime ventilation? At what point people might need?
That's a very good question. Daytime ventilation is introduced typically well after nighttime ventilation, and patients, when they come to visit me, will get a daytime awake carbon dioxide reading, an end-tidal carbon dioxide, and when that level starts to get up to the upper limits of normal, which is above 45 millimeters of mercury, then I will go ahead and introduce mouthpiece ventilation, otherwise known as SIP or sip and puff ventilation. And that would be using a ventilator similar to what is used at night, and using a ventilator circuit that's through an articulating arm that can be attached to the wheelchair, putting the mouthpiece right near the mouth, allowing a patient to use it either continuously or on demand. And it really allows an increase in functionality during the day.
At what age should someone get a first set of pulmonary function testing, and how often should they get pulmonary function testing if they're showing no signs of needing nighttime BiPAP support? That's a great question. So most of our experience comes from retrospective review of the data that we have, but what's difficult is probably prior to the age of 5 years of age, it's hard to get really good quality pulmonary function testing or spirometry results. You can argue, though, that prior to that point in time, there can be some evidence of decreased pulmonary function, just is unable to be measured on spirometry testing. So we typically say that starting at age 5, there should be pulmonary function testing occurring approximately every 6 months. Now, if it's completely normal at age 5, you can wait until age 6. We believe that once the forced vital capacity is at a level of 50% predicted, and that's based off of equations based on male versus female height and age. Once you go below 50% predicted, that we believe that's kind of a cutoff, or from our perspective, kind of a point when there typically is nocturnal hypoventilation. So that's a very important kind of, for us, like a litmus test or a marker of the need for initiation of nocturnal non-invasive ventilation in the form of BiPAP. And as Dr. Meyer pointed out before, sometimes it's very hard to get a sleep study performed locally in a children's hospital. In that instance, if you're waiting for a sleep study and the pulmonary function demonstrates a forced vital capacity less than 50% predicted, that in itself can really demonstrate or point towards indication towards BiPAP. And sometimes we recommend that the first sleep study performed, if the forced vital capacity is less than 50%, that first sleep study could be a split study, meaning half the night on BiPAP, half the night off BiPAP. First getting off BiPAP, then starting BiPAP, to kind of help accelerate the process towards starting BiPAP. But in those patients that are getting consistent pulmonary function testing, starting at age 5 and every 6 months if the first testing is abnormal, or once a year if the first test is normal, knowing the natural history that patients with ulnar congenital muscular dystrophy typically need to start BiPAP by around age 10, and those intermediate patients typically need to start BiPAP more or less around age 21 or plus or minus a few years. Keeping that in mind, that kind of helps us in kind of recommending that every 6 months would be the overall recommendation starting at age 5.
I think what you said is perfectly reasonable. There are data for normative equations, to produce a predicted value for children going down to 3 years of age, though the success goes down to, in a healthy population, to about 60% for 3-year-olds and then about 70-75% for 4-year-olds. So it's doable with a lot of effort. But I would agree that once you get to 5, you should be able to get reliable spirometry lung function.
I see a question here that just came up. What's a good setting for someone who's starting cough assist?
That's a very good question. For most people, the range that people will shoot for is between 30 and 40 centimeters of water pressure. The person that really popularized the cough assist is physical medicine and rehab doctor named John Bach. Insists that anything below 40 is ineffective, and I think the rest of the community disagrees with that. It really needs to be personalized to the patient. So a younger patient that has a chest wall that is easily mobile may do perfectly fine even with slightly less than 30 centimeters of water. But what we do at our center is we have an experienced respiratory therapist work with the patient and find a pressure that moves the chest, in their opinion, maximally, but is also a pressure that is that the patient can tolerate. And sometimes, for a short period of time, that may need to be a small pressure that may not be completely efficacious, just to allow the patient to get used to using the cough assist. So it's sort of a moving target, if you will.
So it's a question, what can I do to prevent delay progression of contractures? It's a great question. We have not been able to do a study like comparing the effect of stretching versus not stretching, but from our patients that we've learned is that a regimen of daily stretching appears to be helpful in slowing the progression of joint contractures. As I'm sure you all know so very well, it's the joint contractures even more than the muscle weakness, which often limits function. So we think that a daily regimen of stretching the joints, making it part of a routine, is very helpful. Sometimes stretching in the pool, if you have a pool available, would also be a good way to provide that stretch to the muscles. And swimming is also very good for providing, conditioning of the muscles, maintaining function. So the next question, also following up on the relentless progression, very well put, of contractures. What is current research offering for the management of fibrous infiltration of muscle and the medical drug treatment of contractures? Great question. I don't know if Dr. Bonnemann also wants to comment on this.
I mean, there's unfortunately there's no magic bullet to this, and we can combine these two questions here. But it is a peculiarity of collagen VI disorders versus other neuromuscular disorders where contractures also can occur, that the progression of contractures in collagen VI is particularly worrisome sometimes. So contractures in collagen VI can actually progress out of proportion of weakness. In other conditions, often the contractures develop just in the weaker muscle as a consequence of the muscle being weaker. In collagen VI, there is an element to the contractures that is beyond, that is kind of in the connective tissue itself. And collagen VI, of course, is both a muscle as well as a connective tissue disorders. So the management of contractures is complicated, and I think one one has to always keep in mind as the overriding principle is functionality of the patient or the person affected by collagen VI disorders. It's not really always a win-win situation, but you can ameliorate problems and make improve on functionality. So when I say that, so one goal on functionality, for instance, is to keep, if contractures occur and they can't be really redressed to neutral, but at least to work on making them symmetrical, because asymmetrical contractures can be calling for more contractures, particularly in the heel cord. So when one heel cord is particularly asymmetrically affected, then the person is going to be on the toes on that side, developing knee and hip contractures on the same side because of the asymmetry. And also one contracture area that is often not paid enough attention to are the contractures in the fingers, which kind of sneak up on patients over the years, and that can impair functionality quite a bit. As you've seen in the pictures before, there are these typical finger flexion contractures that are always there, but when they progress, they can actually, at the end of the process, really impair hand function, typing, and things that are enormously important for patients with these disorders. And so good attention to that by both physiotherapists as well as occupational therapists, including stretching and splinting, is very important. There are some contractures that respond better to treatment than others. So in general, the contractures of the large joints, the elbows, the knees, are very difficult to conservatively attack. So nighttime splinting and is of course something you can try in elbows and knees, but it's very, very difficult to do, and rarely I've seen that to be effective. The ankle contractures are a little bit better that way. You can combine, of course, your own passive stretches, but also serial casting has been successful in our hands to address ankle contractures, including making them more symmetric. Talking about more invasive aspects of contracture treatment, so Botox has, in our view, no role here, because what Botox does, it weakens a weak muscle additionally. So that's not something we want to do in a neuromuscular disorder where weakness is really driving the disease. So Botox is something that's great for spasticity, where the muscle tone is really pathologically increased and you want to loosen that. But in neuromuscular disorders and muscular dystrophies, the muscle tone is already low and the muscle is already weak, and to decrease that further with Botox injection has no role here. Collagenase injections I have no personal experience with. I would doubt that this is going to be very effective given the complex nature of the connective tissue involvement. In terms of surgeries, surgeries have a role and have been successful in a number of contractures, from torticollis to hip contractures to ankle contractures. Less successful in my experience, although there are probably experts out there, surgical experts, who really can do a good job on that, are knee and elbow contractures because of the risk of a pain and recontracture after the surgery. So that's something that probably needs to be researched more in surgical technique. I'm sure there are some approaches to that are more successful than others. It's just been, in our experience, not the most successful of releases. But torticollis has been, that's kind of a contracture of the neck that's often seen in neonates with collagen VI disorders, has been successful. Also hip and ankle contractures. However, I think the most important aspect of that is to be as conservative and as non-traumatic as possible. So there are now a number of techniques, surgical techniques, that are just doing really finely dosed soft tissue releases, or even just transcutaneous weakening of the tendons to lengthen them as microcuts. All of these techniques are allowing for the patient to be mobilized very quickly, so that there's not a prolonged period in casting and other immobilization, because immobilization really calls for the contractures to recur. After lengthening of a contracture, it has to be mobilized and used. So those are the basic principles behind it. Dr. Foley, do you have any other?
No, I think that you covered everything. I guess just to kind of highlight is that some patients that we've cared for have had surgeries performed on particularly the elbow and the knee that have resulted in a fixed contracture where previously there was more mobility at that joint, and so it's probably a well-intentioned surgeon, yeah. But
those are the ones that really need surgical research. I'm sure one can do one can address those as well, but we haven't seen a really successful approach to them yet. Probably because the contracture is so complicated, just not tendon and muscle alone, but maybe even the joint capsule being involved, and so that will require a bit more work. Oh, the other thing perhaps that's very important for the physiotherapist to pose the question is really to work with the family on a contracture stretching program. So it is really not enough to just stretch during physiotherapy sessions, but really the physiotherapist should have a supervising role here in teaching the family and the patient on a daily rigorous stretching regimen that has to be performed at home, and then supervise it and reinforce it at the actual sessions with the physiotherapist. I think it's important to realize it's not just the visits with the therapist, it's really a daily battle that one has to fight here.
So will I experience bone density loss as a result of losing the ability to walk? That's a great question, and it's only natural when there's not that input from the muscles from walking that the bone turnover is affected. And so it's a natural decrease in bone density which occurs when a patient stops walking. To inhibit bone density loss, vitamin D supplementation can be effective and helpful, and probably the dose that we often recommend would be around 2,000 units a day. It's helpful to check a serum or blood vitamin D level to know where your level is before starting vitamin D supplementation, and then to check it again once you're on a particular regimen. But that can help to decrease the loss of bone density, but it is a natural loss when you're not walking. When should I start taking a bisphosphonate? Bisphosphonates are not really recommended from our experience, particularly in collagen VI-related congenital muscular dystrophies. They have been trialed in patients with Duchenne muscular dystrophy, but they're not without side effects, and so it has not been our standard of care to prescribe bisphosphonates. Gastrointestinal and other smooth, soft tissue concerns. Great question. So does collagen VI affect the soft tissue muscles such as the colon? So I can say the only smooth muscle we've seen involved from my experience has been potentially the bladder, some bladder symptoms which seem to correlate with patients with collagen VI deficiency. But in terms of soft tissue and smooth muscle such as the colon, I don't believe that we've had evidence of that.
No, not really. I mean, it's not. I wouldn't be surprised if there is some, but it may be at the moment more subclinical or not really coming to our attention enough to really pinpoint it. But it is, collagen VI is in smooth muscle. It's also in uterine muscle. So one has to be vigilant about it, I think.
In terms of gastrointestinal and bowel problems, constipation is a common phenomenon, but typically well controlled and treatable. But diverticulitis or inflammation of the intestinal tissue, we don't know of an association particular with collagen VI deficiency, but of course this may play out over time, but at this point in time what we have seen is consistently constipation which responds typically to treatments such as Miralax. The next question regarding mammograms and collagen VI deficiency in connective tissue related to pain. I'm not aware of that. Again, we don't have enough adult patients to comment on that, as well as publications in terms of mammograms for collagen VI adult patients.
No, I mean that the recommendations should be not different from general gynecological cancer screening recommendations, but yes, in collagen VI deficiency, bruising is a bit more common. Even of those of you who've had children who get their blood pressure measured, you can see sometimes you have a little bit of bruising even around the blood pressure cuff. after taking pressure. So there is a little bit of these microbleedings into the skin that are not harmful or anything, but they're more common in collagen 6, probably because the small capillaries are involved here as well. And there is that part. So that, yes, I can see that being a problem in mammographies. But really, we can't make recommendations about breast cancer screening. Really, that needs to be worked out with the cancer prevention teams.
For the next question about aneurysms, this is kind of a question that we are trying to study as well. And the question: are people with collagen 6 disorders more prone to aneurysms? Aneurysms can occur also through familial inherited proclivity towards developing aneurysms. Whether or not what we're seeing is related to collagen 6 deficiency, difficult to say at this point in time. We are gathering data. We have seen a few adult patients with vessel myopathy that have a little bit of widening of the aorta, and we know that collagen 6 is expressed in the intima or vessel walls. But a tendency of being more prone to aneurysms related to collagen 6 disorders is not entirely clear at this time. How, are aneurysms preventable and predictable? So we would recommend that collagen 6 patients undergo typical echocardiogram monitoring of, as I mentioned before, probably every 2 to 3 years. And from the echocardiogram, you can assess the size of the aorta. And if there's any question about the aorta size, further dedicated aorta imaging can be recommended and would be recommended. In terms of when, how often should I be monitored? Again, we've only seen this so far in the adult patients over the age of 30.
So one of the problems, of course, aneurysms, if you do brain vessel MRIs on adult people, you'll find brain aneurysms in as high as 5% of normal people. So for us to, we don't have the numbers yet in collagen 6 patients to say this is higher than what you would expect in a regular population where you screen for that. So we really need higher numbers to answer that question. It's a theoretical possibility, and vigilance is good, but we can't make a correlation just as yet whether those are actually indeed more common in collagen 6 patients than there would be in normal people who also have aneurysms at a certain rate. And then there's a question from Jennifer here. Besides bruising, is there any other consequence of capillary involvement? Not to our knowledge of this. And so it's really this kind of microbleeding in the skin that you see after compression that we've seen in patients with collagen 6 disorders. It doesn't seem to have any consequences that are worrisome, and we haven't seen a problem with that in other tissues.
So for diet, vitamin supplements, so the article which is quoted here on autophagy is an article which Dr. Bonnemann and I have reviewed in great detail. And the question is, should we be switching to low protein diets, and what is autophagy? Autophagy relates to the body's, the cell's process really of kind of trafficking out waste from the cell, and there's data that this process is abnormal in collagen 6 deficiency. The article, which is on the slide here, which refers to a low protein pilot trial. We have some concerns about the data from that article, particularly because protein is very important for muscle, maintenance of muscle, as well as the fact that there's some evidence in this small trial that patients that participated had a decrease in muscle mass, weight, and body mass index. In particular, the article states that there's a 7% loss in muscle mass. So taken together, we feel that based on the data presented so far in this paper, we would not recommend a low-protein diet. Any other general advice about diet, nutrition?
Yeah, I think the autophagy problem is, like Dr. Foley said, it's something that's been seen on a cellular level in the mice and some of the muscle biopsies from patients, and it is a phenomenon that is real, but how disease relevant it is still to be worked out in detail. And so the pros and cons, if you weigh them, then protein restriction has, in our view, too many cons to outweigh that. And so we, as Dr. Foley was saying, we would not advise to try to speed up your autophagy by protein starving and decreasing muscle mass. So I think that's the current status of what we would recommend. Other general advice about diet and nutrition? Not really. I think a balanced, healthy diet is really key. And one of the things that is also key is to watch the weight carefully in either direction. So many patients with collagen VI disorders are rather skinny and may have a weight that is below normal, but what we, particularly in growing children, do not want to see is that the weight actually drops off or becomes more and more abnormal compared to normal. So we allow for children to follow their own weight curve, but if it plateaus or drops off, that is a reason for concern. And the flip side is true as well. So some patients with collagen VI disorders have weight problems, so they put on too much weight, and that of course is also the result of less physical activity with a neuromuscular disorder in general. A flip side of that is that increased body weight makes it harder to move and makes daily activities more difficult. And so that's where I think a healthy diet with exercise, which is coming up later, comes into play. And sometimes it may even be important to get a dietitian or dietary person in the neuromuscular team involved to really devise a diet plan. But it doesn't have to be any kind of weird or strange or diet that you need to follow. I think regular healthy diet is really all that's needed.
And the question about hydration or lack of affecting symptoms, we would always recommend a good level of hydration. Limiting hydration can be an issue. Sometimes some of our teenagers will limit hydration because it's hard to get to the bathroom during the school day, but hydration is very important overall just for normal body functioning. So in terms of affecting symptoms, we're not aware of effective symptoms from hydration. Just to be a kind of a general recommendation to have good hydration levels. Sometimes in the setting of low hydration, there could be more of a tendency towards developing a kidney stone, but again, that would be severely low hydration, so recommend good hydration. In terms of vitamin supplements, as Dr. Bonnemann pointed out, it's very important to have a balanced diet. The best source of vitamins and minerals will be from food sources themselves, and so there's not really an abundance of data that particular vitamin supplements would be beneficial. There is more anecdotal evidence that supplements such as coenzyme Q10 in the form of ubiquinone can help to promote overall cell energy and sometimes muscle stamina. But again, there's not been a trial of the use of coenzyme Q10 versus not using it to show that it definitely makes a difference. But if you wanted to try coenzyme Q10, ubiquinol is better absorbed from the gastrointestinal tract than ubiquinone. But again, it's not clearly correlated with an improvement. It's much more data has been seen in, or experience has been in patients with mitochondrial dysfunction. And in collagen VI deficiency, there can be potentially some secondary mitochondrial dysfunction, but not primary mitochondrial dysfunction. So therefore, there's not clear data with the indication for coenzyme Q10 or ubiquinol supplementation. My kid catches a lot of stuff at school. It's hard to keep her attendance up. So in terms of immunity, that's a tough question. I mean, I think a balanced diet is probably the best recommendation of all. And then in the setting of any upper respiratory infections, increased frequency of use of the cough assist in the inhalation mode is very important for expectorating or bringing up phlegm and preventing that phlegm from going lower into the lungs and becoming a significant chest infection. So boosting immunity, I would say in general, a balanced diet would be most important of all, plenty of fruits and vegetables.
Related to that, Dr. Foley, this is Hank Meyer, the pulmonologist. I'd just emphasize the importance of being very proactive in doing assisted airway clearance during acute illnesses, even ones that are focused on the upper airway, just because of the potential for progression and getting to the point where one might need more intensive care in the hospital.
Oh, exactly. No, thank you for highlighting that, Hank. And also, I think probably from the pulmonary medical literature that good nutritional status has been shown to be really helpful and a helpful defense for any potential infections. So that would be important to have being a good nutritional status. I see a question here about evidence for plant-based diet as beneficial. I don't think we have that evidence. I saw a question here, but also about data on selenium in muscular dystrophy. We don't have particular experience with indication for selenium per se with collagen VI deficiency. I do know there's some data in the FSHD literature, but not per se for collagen VI. So again, a regular balanced diet would be most important of all, and a good nutritional status, very important for keeping overall health in a good place. I'm going to move, I guess, to exercise. So great questions. How much should we exercise, and can exercise cause damage to our muscles? So from what we know, based on some research has been done in other muscle conditions as well as our experience with our patients, is it is important to exercise, and recommended exercises would be those that are kind of low intensity but consistent exercise regimens, such as swimming, and stretching is important as well, kind of on the spectrum of things that are important for exercise. But how much, as much as would be feasible in the daily routine. So I think definitely daily stretching is important. Swimming, if there's a pool available, is very helpful. For those patients that remain ambulatory, walking as much as tolerated is also very good for maintaining function. We don't recommend ever overdoing anything. So anything excessive which causes muscle pain would be overdoing it. And in terms of exercises that can cause damage to muscles, so there are different types of contractions of the muscles. We like to avoid the eccentric contractions, which are the ones that would cause muscle breakdown. For example, if you are using a lightweight, again a lightweight, to do a curl per se of a dumbbell, when you curl up the dumbbell towards your shoulder, that would be a concentric contraction, which is okay. Again, don't overdo it, but the one that is damaging would be that release of the dumbbell or weight from a curl position to releasing it downward or extending the elbow. That causes an eccentric contraction, which causes muscle breakdown. This is what bodybuilders use to build muscle, but it's not recommended in patients with collagen VI deficiency because there's a decreased ability to build up muscle, which is loss. We want to prevent any imposed from exercise loss of muscle. To that.
No, I think this really covers it, but really, rather than, so exercise is more beneficial than it is risky, is I think the bottom line, and it's probably very hard for a patient with collagen VI to really damage the muscle with exercise, and the type of exercise that most patients will do is the exercise Dr. Foley described, which is kind of cardiovascular exercise on a bike in the water, and that type of exercise certainly is good and beneficial for muscle and also for lung function. I think the evidence is mounting for all muscle disorders that skepticism to exercise, or the worries that exercise could actually damage muscle a little bit, I don't want to say overblown, but they shouldn't be taken as an excuse to not do exercise, if you will. And the exercise together with the nutrition is really something that has been shown to improve muscle endurance, muscle volume, so preventing atrophy, improve bone health, improve pulmonary health, and overall well-being for the patient. So something that really should be, if possible at all, should be in the program of treatment. It'll be, of course, a matter of how much, and so as you all know probably from just reading the popular literature in exercise in general, a rule of thumb is 3 times a week is really what you should try to achieve as the minimum. But it'll be, of course, different from location to location of what can be done, and also depending on the degree of immobility or mobility that a patient has with collagen VI disorders. But make it a point together with your physiotherapist to try to find some way of including exercise into the regimen of treatment.
I guess we could also just say, kind of adding on one last point, is that we have seen from our collagen VI patients that they have no difficulties exercising their brains by any means, but exercising the muscles obviously more of a challenge to get a regimen for that, but very important. Move on to other health concerns. So tendency towards getting very cold or temperature sensitivity, it's not clearly been correlated with collagen VI deficiency that I've seen, or we've seen in the literature. Is restless leg syndrome a common problem? Also not clearly correlated. Again, it's difficult because sometimes these can be inherited proclivities towards getting cold or restless leg syndrome, which may be inherited from different genetic mechanisms distinct from collagen VI deficiency. Have there been any studies on pain management? No. In collagen VI deficiency, pain would be probably more related to overuse of muscle or progressive scoliosis in our experience, but studies dedicated to pain management have not been performed. And again, in the setting of skeletal muscle pain, we recommend not overdoing exercises, and in the setting of pain due to positioning, due to scoliosis, typically scoliosis repair is considered in those patients with progressive scoliosis, which is causing pain. And it's important to also reevaluate the sitting arrangements, the wheelchair positioning, to decrease the tendency towards discomfort. Are there any studies on the effective management of mental health issues that stem from having this or other rare diseases? How are patients, caregivers, and physicians handling these issues? It's a great question. It's been also raised before other forums. So I think, have there been studies? Not that we're aware of studies being dedicated to management of mental health issues. I think one thing that we've learned from patients and caregivers is having forums such as this and having forums such as Cure CMD are very important, particularly so individuals affected with collagen VI deficiency recognize that they're part of a wonderful large community and have that as an outlet for discussing experiences and as well as sharing advice. But in terms of studies of effective management of mental health issues, I'm not aware of any. I don't know if you or Dr. Bonnemann.
No, I mean, it is certainly nothing that is specific to collagen VI, but it is, of course, something that shouldn't remain unrecognized in patients with collagen VI disease. And so to have a mental health specialist to address that as part of your care team is certainly very important, and also for the care team to always, investigate whether that is a hidden aspect of the disease. Sometimes in adolescents, in particular, they will not volunteer that they're actually, to what degree they're affected by the disease, including depression. So that needs to be addressed head-on by the care team, I agree.
And I guess I would also encourage, if your care team is not inquiring about mental health, it'd be important to share the information with your care team. Next question, are you aware of any antidepressants or anti-anxiety medications contraindicated for collagen VI? Not that we're aware of. I've been told that losartan, an antihypertensive, may be beneficial. Why should I start taking it? If it's been indicated by your cardiologist, that's one reason for taking it. If you have heard that it's maybe beneficial for congenital muscular dystrophy, that data is more in relation to Marison-deficient congenital muscular dystrophy or LAMA2-related congenital muscular dystrophy, stemming from preclinical mouse models. I don't know if you want to add to that.
The effect of losartan here wouldn't be an effect on blood pressure, but it is an effect on a pathway that can increase fibrosis, meaning scar formation in muscle, and that's been looked at in Duchenne muscular dystrophy, Marison muscular dystrophy, Marison-deficient muscular dystrophy, as Dr. Foley was saying, and losartan can interfere with that pathway. And we're actually actively looking at that as well in collagen VI muscular dystrophy. So there may be a role for that or similar medications as we go forward, but it is really too early to put yourself on that, given that there's also risks associated with it. But it's something that's certainly under active investigation. It may be something that will happen in the near future if studies look promising. And
for the last question, I've been told that statins are contraindicated people with neuromuscular conditions. Why? If cholesterol is an issue, is there an alternative? This is a great question. So some patients are prone to what we term statin-induced myopathy, and that's probably why you've heard that it's been contraindicated in patients with neuromuscular conditions. If cholesterol is an issue, is there an alternative? I mean, probably be recommended that you would consider other medications, but again, it's a conversation you should have with your cardiologist about that. Not all patients develop a statin-induced myopathy, but because of the risk, and if that's being considered as medication in the setting of of collagen VI deficiency, probably better to consider other medications if they would be options. Prevalence. What is the estimated prevalence of collagen VI? Great question. We have relative frequency data from the UK congenital muscular dystrophy cohort, but in terms of prevalence, we don't know the exact prevalence. It seems to be that it is perhaps the most common form of congenital muscular dystrophy, but the prevalence is difficult. We do know it also qualifies as a rare disease, both from the EU definition and the US definition. Is Bethlehem or Ulrich, or the intermediate form, more prevalent than the other phenotypes? Dr. Bonnemann, I don't know if you want to comment. I mean, I know our data from the international cohort, we had predominantly, actually just over half the patients were Ulrich, and then we had quite a number of Bethlehem, and then much less, actually 11 patients out of 143 that were intermediate for that study.
Yeah, I think it's still a moving target, and of course the more classical the phenotype is, the more readily it's going to be diagnosed. And so the patients with classic Ulrich have a higher chance of being diagnosed than patients with less typical presentations. That goes into the next question also. If it's mild and is in older people, it may not be recognized as readily as it is in young children with the typical presentation. So with more readily available genetic testing, that landscape is probably going to change, and we're going to see hopefully a more complete picture of collagen 6 across the ages, but I think that's still evolving.
For the questions for research and treatments, when will the results of the phase 1 pharmacokinetic Callisto study for Megapil be published? So at this point in time, we project that the trial will be completed by late October or early November, approximately, and after that point in time, there needs to be a full statistical analysis of all the data. So when would it be published? I mean, ideally within about approximately a year to year and a half time from the completion of the study, but that again is hard to predict based on the timeline we have now. The study would finish in October or early November. So the phase 2 study basically would be based off of the decision of not only the sponsor but also regulatory agencies, whether it can go forward to phase 2. I know the sponsor is hoping and intending that it would go forward, and would it take new participants using those or those currently enrolled. This is all yet to be determined. And in terms of also any requirements for pulmonary status, would it be expanded? Again, yet to be determined. So this first study was, primary outcome is basically safety, tolerability, and pharmacokinetics. And so based off that data, that will determine any details of further trials, and also the inclusion criteria for such trials, including age range. Is it possible that a Megapil or a similar drug will benefit affected adults? It's a great question. I mean, adults are often seen as a very good clinical trial participant. And particularly since this drug has already been tested in adults for different indications, namely Parkinson's disease and ALS, there's more of a level of confidence of the use of this drug in adults, whether or not it will provide a benefit. It's hard to know. This study the present study, the phase 1 study, is too short to measure benefit. So there had to be a longer study in terms of looking to measure efficacy or benefit over time. But again, we don't know the details of that study just yet. It depends on multiple factors stemming from the analysis of the present study's data.
So gene therapy is complicated in collagen 6 because the genetics of collagen 6 is complicated. I said at the outset there's two ways of getting collagen 6. One is recessive, where you're basically losing collagen 6, and the other one is dominant negative, where you have a toxic or interfering copy of collagen 6 hanging around that is kind of taking down the normal collagen 6 that's also there. So for the scenario where collagen 6 is missing, the recessive scenario, which admittedly is not as common, gene therapy, meaning replacing the collagen 6 gene, is an option. At least for the smaller collagen 6 genes, alpha 1 and alpha 2. And that's being tried in a mouse model at the moment as well. That'll be not applying, though, for the patients with dominant negative or the toxic type of mutation. For that, we need to come up with other ways. And that would be a form of gene therapy or gene manipulation that's directed at knocking down or knocking out the dominant negative or toxic copy with a mutation. Because if you only have half normal collagen 6, you're living actually quite fine with that. So we only need really 50% of collagen 6, but collagen 6 has to be all normal, and with a toxic copy there, you're dropping below 50% of normal collagen 6. So the way to address that is to knock out the toxic or dominant negative copy, bring it down to 50%, which is tolerated. And there's a number of ways to do that that are being addressed in a number of laboratories at the moment, including our own, which is processes called RNA interference or antisense treatments, where you design molecular probes directed at the abnormal version of collagen 6, the abnormal readout of the gene, and you knock it out to have it be not interfering with the normal collagen 6. And the same can actually be done with CRISPR, and that again is also something we try, is to basically use the CRISPR gene scissors to go to the mutant gene and cut it up so that it's not being produced. So you really you cut out the mutant gene at the level of the genome with the CRISPR technology. Something that's absolutely feasible and makes sense, but it's of course a bit removed from clinical translation because the safety issues of CRISPR gene scissors are not fully investigated, because really you want CRISPR only to cut where it's supposed to cut. If it cuts anywhere else in the genome, that could be a big problem. But proof of principle, yes, so CRISPR is applicable to this problem as well. Collagen 6 amendable to exon skipping, yes, so there's one particular mutation that we've just discovered that is actually not so uncommon, where there is an extra exon that doesn't belong there. That is a mutation that can certainly be addressed with exon skipping. All of these therapies, by the way, are mutation-specific, so they're basically tailor-made treatments, precision medicine, if you will. The treatments designed to the particular mutation a patient has. It's not something that is making this impossible to move into clinic. It is actually the, I think, where modern medicine is heading, to design treatments that are really more mutation-specific. And so exon skipping, CRISPR, and the knockdown are all this type of treatment, precision design treatments for these types of mutations. But we do know that this is feasible in principle and needs to be now perfected to be able to move that into the clinic. I see there is a path forward for that very clearly, and that answers also the last question. I think that's the most promising avenue at the moment for this. Stem cell therapy is, I'm a little bit more skeptical about that, because that is an issue that has two issues to it. One is, which cell do we want to replace in collagen 6? Particular interesting aspect of collagen 6 is that the cell that's carrying the mutation and causing the problem is not the muscle cell itself. It's cells within muscle that make connective tissue. They're called the interstitial fibroblasts. So you could say, well, I find a treatment to replace those so that they make better collagen 6, and that is certainly something that's been attempted in direct injection. But really the problem for all these therapies is body-wide correction. How do you treat this huge organ that we have, which is skeletal muscle, so that every muscle gets corrected with cell therapy? And that's been an unsurmountable problem in all muscle disorders where that's being considered. If someone has a breakthrough in any other muscle disorder, it could really very well apply to collagen 6 as well. But I don't think that's an immediate issue. All the stem cell therapies that are out there, that are advocated, that are actually done in sometimes shady circumstances, are not to be recommended. This is not something that will work. There's a lot out there recommending stem cell therapy, or even doing stem cell therapy, quote unquote, in patients with a number of disorders, including muscular dystrophies. This is not going to work and is potentially dangerous. So stay away from that. Any other drugs being tested that may have application for collagen 6? Certainly. So there are a number of general muscle-directed therapies that could have direct implications to collagen 6 as well. An example would be therapies that are directed against muscle atrophy or muscle wasting in general. Those are therapies that Big Pharma is also interested in, because there's so many muscle wasting disorders out there, including cancer muscle wasting, old age muscle wasting. All of these could be potentially applicable to collagen 6, because muscle wasting is an aspect of collagen 6. And those are therapies that look at growth factor pathways to boost growth factors. myostatin therapy even is something that is applicable there as well. And also what we mentioned before, the losartan or anti-fibrotic treatments could also be extended to collagen 6. And we now have animal models for collagen 6, so it's possible to pre-test all of these relatively quickly. But they're on the horizon for collagen 6, absolutely. I know the genetic bit is a bit complicated, so if you have additional questions about that, please feel free to ask those. But it's something that we're really struggling with, but I think we have a way forward for that too.
Thank you so much, Dr. Bonnemann, Dr. Foley, Dr. Meyer. We really appreciate your time. We really appreciate the questions from the community. It kind of keeps us all on our toes as to what is important to families, affected individuals. Sometimes I think we all get tunnel visioned on how do we cure this, but I think the day-to-day living aspects are important to be reminded of periodically. So if you have any additional questions or comments, please get in touch by email. This email comes directly to me, and I will make sure that if I can't answer your question, I will reach out to our experts and see if we can put you in touch and get the answers to your questions. But in the meantime, please stay engaged. We have a really great Facebook community for Collagen 6. There are 2 Facebook groups and also the CMD general support group that are all incredibly great places for you to share and ask questions of other families dealing with these problems. And also, please make an effort, if you can, to come to the conference that we're holding in July. This is another great opportunity to meet these fantastic experts in person and share your story with them and with other families. So with that, I think we'll close. Again, thank you so much for everybody's time today.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.